Good evening and welcome to the Smilow Shares Early Stage Breast Cancer session entitled What Patients and Families Should Know. My name is Dr. Rachel Greenup. I'm the Chief of Breast Surgery at Smilow in the Department of Surgery at the Yale School of Medicine. And tonight we have three of our esteemed colleagues, Dr. Elizabeth Berger, Dr. Siba Haykal, and Dr. Mariya Rozenblit. And we're going to start with Dr. Berger, who's an assistant professor of surgery in the Division of Surgical Oncology, who will be talking to us about surgical updates in breast cancer. Dr. Berger, welcome.
Thank you so much for that kind introduction, Dr. Greenup. Let me share my screen. I get a thumbs up so everyone can see it. Great. So tonight I'm going to spend about 10 to 15 minutes talking about some of the kind of updates of as far as surgical care in early stage breast cancer. And I appreciate the time, and hopefully we'll have time for questions at the end if there are some. So the way we stage breast cancers in just kind of context as far as early stage goes is multiple different ways. We think about how big the tumor size is, how many lymph nodes may or may not be involved. And we essentially come up with a stage of breast cancer. And Dr. Rozenblit will probably get into this in more detail, but the biology of tumors now is so much more important than stage, but we still stage breast cancers based upon the staging schema. And what we'll be talking about tonight is really this category of kind of stage 0, if you will, to stage 2 breast cancer is considered early staged. Stage 0 breast cancer, kind of an enigma and doesn't make that much sense, but we really refer to what's called ductal carcinoma in situ as stage 0 breast cancer. Or for a lot of my patients, when I say a precancerous process, it's in situ disease, meaning, the abnormal cells are contained within the ducts. There's no invasion that we've identified. And so we really think that this is a precancerous lesion or stage. We used to think that we should take all of DCIS out, we should remove it surgically, because we thought all DCIS became an invasive cancer at some point. Now what we know with ongoing clinical trials is maybe some DCIS never becomes invasive cancers, and we can actually safely observe or survey DCIS without actually having to remove it. So stay tuned. Hopefully in maybe 2030, we'll hear more about stage 0 or precancerous lesions such as DCIS being able to stay in the breast, not have to be removed because of these ongoing clinical trials. So much of breast cancer care, as I think everyone on this call knows, is really based upon really good clinical trial data, which is really exciting for all of us as providers and for patients. So if we're going to talk about surgery for breast cancer, because surgery for breast cancer is still important, we think about kind of where we've been and where we're going. So Dr. Holstead used to perform what's called the radical mastectomy, where we'd remove the chest, the breast, the pectoralis major and minor muscles. And now we know for breast cancer care that we can really preserve the breast. We can often do what's called lumpectomies, where we do breast conservation and not remove the whole breast, and give patients similar, the same outcomes from their cancer care. So I recognize, but the point of the slide is that in the 1970s, we started to ask these big questions for surgical care for breast cancer. And we realized that in the 1970s, we didn't have to remove the whole breast, and we could do breast conservation with radiation. We then, if we pivoted towards the 1990s, realized that we didn't have to do so much axillary surgery for early stage breast cancers. The Z11 trial was instrumental in allowing our patients to have less axillary surgery, even if they had a few lymph nodes with cancer in it. And now fast forward to the, kind of present time, where we can do maybe even less surgery for DCIS, and we just observe DCIS. So these are some of the really important practice-changing trials for breast cancer care, especially in the early stage setting. We even may go as far as to say, and again, a little bit more in advanced breast cancer settings, but we even may go as far as to say, if a woman gets chemotherapy before surgery and there's no cancer left in the breast, we may be even able to avoid surgery altogether. This is, I think, too early for prime time, not ready yet, but something potentially down the pipe. So if we are going to do surgery for early stage breast cancers, what are some of the updates? And I'll go through these in a kind of brief review as far as thinking about, we do have non-cancerous lesions that we often take out for breast, as breast surgeons. We do a lot of now more oncoplastic work, which I'll touch on briefly. We have some nipple sparing mastectomy updates as far as sensation preservation and potentially different options for reduction of lymphedema. So a lot of women will get diagnosed with these things called high-risk lesions. They're not actually breast cancers, but sometimes if they're in the breast and we remove it, we may find some underlying, essentially precancer or DCIS diagnoses. So if a woman gets biopsied and has what's called atypical ductal hyperplasia, it is something that you want to consider seeing a breast surgeon for, because it may be something we would talk to you about removal of. Some women get diagnosed with what's called LCIS or lobular carcinoma in situ, and it's alarming for patients, and often get a phone call from their primary doctor saying, you have an carcinoma. But what we know about LCIS, that we actually don't need to take it out. It doesn't become a breast cancer, and it's something that we can watch, recognizing that it's a marker of risk. And then, further things in the breast that can be diagnosed are radial scars and papillomas, all sometimes, again, consideration of high-risk lesions. Some we recommend excision for, and some we don't recommend excision for. A lot of women ask, well, how are you going to find you're going to be able to identify to get the tumor out? And unfortunately, that little biopsy clip that gets left is not big enough for us as breast cancer surgeons to find on our own. So we need some help to be able to find that lesion. And it's always disappointing for the patient when we say we have to put in another thing into the breast before surgery, but it's very helpful for us to be able to find accurately and pinpoint exactly where we need to go. So we used to use wires, and now, because of all the sometimes chaos that can happen with wires, sometimes we'll use what's called a tag, or even a smaller device that goes into the breast a few days before surgery, and then often doesn't delay surgeries. A patient can get it, a few days before on their own time, and it allows often to options, a little bit at different locations of the breast. Wires are still used. They're great technology. It's a very kind of surgeon preference and personal preference for the patient as well, but they're just different ways to think about localization. Some women will come into our clinic with, these very large areas of, for instance, calcifications, or even a large breast tumor, where, we recommend surgery first. And sometimes, there may be no other option but a mastectomy. But sometimes we have really nice options where we can do a very large resection and work very closely with our plastic surgeons, Dr. Haykal and others, where we can do what's called an oncoplastic reduction. And so it allows us as breast cancer surgeons, even in early stage breast cancer, to take out a large piece of tissue, and really reduce, or do what's called a mastopexy, a lift of the breast, and leave a woman with an amazing reconstructive result, but still take out a fair amount of breast tissue, and get out the cancer safely. When we are taking out early breast cancers, we always want to make sure that we get clear margins around the cancer. And I think can be a very confusing for patients to understand. So when we think about clear margins, what we want to do is we want to take out the cancer, and then we always want some healthy breast tissue around that cancer. And so, unfortunately, when we have what's called a positive margin, what that means is what we hope is healthy breast tissue. Again, unfortunately, this is all microscopic disease. What we thought a healthy breast tissue margin we removed comes back underneath a microscope with some cancer on the edge of that margin. And that does often require us to go back to the operating room with the patient to take, again, a little bit more tissue. Doesn't mean that the cancer has spread all over, or it doesn't mean that we missed something per se. Unfortunately, we don't have x-ray vision. If we did, that would be awesome, but since we don't, it's just a matter of where the pathologist, the doctors that look at things underneath the microscope, really have to examine that tissue to make sure that the cancer cells are clean of the edge. We also want cancer cells clean of the edge when we do DCIS surgeries as well. And we always kind of shoot for this idea of 2 millimeters from the edge of the piece of tissue when we take out margins. Um, at Yale, the study done to look at margins when we do remove breast tissue around the cancer was done by Dr. Chagpar, who's no longer here at Yale, but she led this trial at Yale. And it was a really well done trial to show how we can take this healthy breast tissue around the cancer. As far as some of the mastectomy updates for early stage breast cancers, so when we think about mastectomies, there's multiple different ways to do mastectomies, multiple different types of reconstruction. And one of the ways now is what we can do is called a nipple sparing mastectomy. Yes, we know ducts do go into the nipple. And so sometimes there's fear that, that may increase a woman's risk of developing a breast cancer if they have, for instance, the BRCA gene and want a prophylactic mastectomy. Or it may, there may be some fear about risk of recurrence if a patient has cancer and has a nipple-sparing mastectomy. And a lot of really well-done trials, you'll see Dr. Greenup on this study, I should say. There's been a lot of work done in whether or not nipple-sparing mastectomies are safe for our cancer patients in the early stage setting and in the prophylactic setting for our BRCA carrier patients. And what we've found from multiple trials now, or studies, I guess I should articulate, is that it is a very safe procedure for women to have done. Not everyone will qualify for a nipple sparing for various reasons, but in the setting that it's a reasonable operation for a patient, it's safe. Contralateral prophylactic mastectomy. So this is a whole nother discussion about when a woman has an affected breast with breast cancer. What about removing the other breast? There's a lot of discussion about whether breast cancer spreads from one breast to the other, and that's actually not the case. We know that breast cancers don't spread from the right breast, for instance, to the left breast, but we do know that a woman's at a higher risk of developing a contralateral cancer if they have a breast cancer in one of their breasts. What we do know is that removing the contralateral breast does decrease that woman's risk of getting a breast cancer, but doesn't improve their survival from their actual cancer in their breast. It's something to consider. It's definitely a conversation to have with your surgeon. And some women elect to do it for very personal reasons, and some women don't. It's just something to always kind of think about. As far as nipple sensitization now, so there is some data to suggest that we may be able to re-neurotize or essentially give sensation to the mastectomy skin when we remove the breast. Oftentimes we remove the breast, the skin is innervated or gets its sensation from the breast. And so the skin loses sensation, it becomes numb. And now, there is some ability to find these nerves along the outside part of the breast, connect what's called an allograft. So it's a cadaver nerve, and then sew that also into nerves underneath the nipple to try to preserve some sensation. There's some data to suggest that it works, and then some data to suggest that it's not perfect, and that it doesn't always work. And so I think this is, kind of to be continued. I think often it's worth a try. And then, sometimes, we'll just have to see what the data shows as far as long-term outcomes, because it may not hold true for every woman. Um, there's been a lot of changes in the way we think about removing lymph nodes underneath the armpit for early stage breast cancers, which is really exciting for patients. We used to have to remove all the lymph nodes underneath the armpit all the time, and it caused a lot of morbidity for our patients. And now what we know, we can really only have to remove a few lymph nodes often, called a sentinel lymph node biopsy, and leave the rest of the lymph nodes to avoid that really, unfortunate risk of what's called lymphedema, the swelling of the arm. As I spoke earlier on, the Z11 trial was the trial in the early 2000s that showed us that if a woman has only 1 or 2 positive lymph nodes at the time of surgery, we don't have to necessarily remove all the lymph nodes. Now we even know that with women who have early stage, slow growing cancers, the hormone receptor positive breast cancers, we actually don't even have to remove lymph nodes at all. So we don't even have to do that sentinel lymph node biopsy. If a woman has small cancers, hormone receptor positive, 2 trials were done kind of right near each other, one in Europe and one in the UK, that showed us that there was no difference in outcomes whether we actually remove lymph nodes at all. This was just a little bit more detail on the sound trial that allowed us, again, to show if a woman has a normal axillary ultrasound before surgery, we do breast conservation, we don't have to remove lymph nodes. And this was the Ensema trial in Europe, again, showing essentially the same results. As you can see, the surgical complications are real when we have to remove lymph nodes, and they did a really nice job demonstrating that when we omit removing lymph nodes, women have a lot less surgical complications. We give neoadjuvant chemotherapy, meaning chemotherapy before surgery, and sometimes still early stage breast cancers if they're more aggressive, like the triple negative setting and the HER2 positive setting. And now what we know is that if we remove lymph nodes after chemotherapy, and there's no cancer left in any of them, we don't have to take out all the lymph nodes underneath the armpit. However, stay tuned because even now, when we have a few lymph nodes that still have cancer in it after chemotherapy, we may not need to take out all the rest of them, and we may be able to offer the patient radiation alone. So these results are hopefully coming in the next 4 to 5 to 10 years, but I think this will be practice changing for our patients as well. And Dr. Haykal may get into this in a little bit more detail later, but we now know that if we do have to remove all the lymph nodes, even still for an early stage breast cancer, it can happen. We can do techniques now to hopefully avoid the horrible complication of lymphedema, where we can connect a vein and a lymphatic, a little channel in the armpit. And again, ideally allow our patients to suffer less from potential complications of lymphedema. There are ongoing clinical trials in this country looking at this very idea to hopefully have to show that there are good outcomes with it, but stay tuned as well. And I think that's all I have. Thank you so much for the time, and I'd love to take questions at the end.
Thank you so much, Dr. Berger. And we're going to move on to our 2 additional speakers. We'll take questions at the end, and I'll be responding in real time in the chat. This is really meant to highlight our multidisciplinary team approach. Next up is Dr. Siba Haykal, Associate Professor of Plastic Surgery and Section Chief of Oncoplastic Reconstruction. Tonight, she'll be talking about breast reconstruction and early stage breast cancer. Thank you, Dr. Haykal.
Thank you so much, Dr. Greenup, and thank you, Dr. Berger, for an amazing talk. I'll be sharing my screen. Please let me know if you can see it. Great, thank you. Okay, great. So we're going to talk about breast reconstruction, and I'm open to questions at the end. Hopefully I can answer some of the questions by going through some of the slides and some of the techniques where breast cancer surgeons are working in collaboration with reconstructive surgeons in order to achieve a great outcome. So let's talk about breast reconstruction. So it can either be immediate, which is at the time of mastectomy, and we'll talk about lumpectomy as well, or it can be delayed, which is any day after the mastectomy. How do we determine the best options, and how do we make a decision? So it has to do with patient preference, the need for postoperative treatments such as chemotherapy or radiation, whether we have donor sites, and I'll talk about what that means, other medical issues, and recovery time. So I'll first talk about oncoplastic reconstruction. So Dr. Berger mentioned it a little bit, but oncoplastic reconstruction basically involves rearranging breast tissue after a lumpectomy for breast cancer to achieve a better aesthetic result. So when a portion of the breast is removed, it can cause some dimples, some divots in the breast, and it can cause some asymmetry between the 2 breasts. So this is a great option for people who have large or very what we call ptotic or saggy breasts. So a breast reduction is typically done on the other side as well, and or a breast lift. Now let's talk about implant-based reconstruction. So there are some techniques that involve putting in an implant right away. So that's when we put an implant at the time of a mastectomy. It eliminates the need for what we call a tissue expander. It's a breast reconstruction that can be completed in one step. And people who are good candidates for this are really based on the breast size, the cancer size, and the type of mastectomy required. And frequently it's done when we try to keep the nipple areola. However, this is not the gold standard. It can lead to high revision rates. The gold standard for implant-based reconstruction is what we call a two-stage procedure. So in the first stage, we put either a tissue expander above or underneath the muscle, and most commonly now above the muscle. This looks sort of like a balloon. It has a magnetic port in it, and it's covered by the skin. And this requires filling of that balloon in clinic every 1 to 2 weeks, and we fill it to the size that we're happy with or you're happy with. And it involves the second stage. So that means going back to the operating room, removing the expander, and putting in an implant. This is kind of what it looks like. Sometimes it's covered with a special type of mesh. And in clinic, we use a magnetic finder. We find the magnetic port and we put a needle through the skin into the tissue expander, and we fill up that space. So typically we start filling about 2 to 3 weeks after surgery. The expansion process can take up to treatment is required. What are the advantages of implant-based reconstruction? It's a quicker procedure. It's a shorter recovery time. You get to choose the size of your reconstruction. We're only operating on one side. The disadvantage is it can be more than one surgery. We can sometimes see and palpate the implant. If it's placed under the muscle can cause animation. There's always a risk of infection. There's a risk of what we call capsular contracture, which is the body forming a capsule around the implant, which commonly happens. However, sometimes it can become hard and painful and can distort the implant. Implants can also rupture. Any radiation can lead to a higher failure rate. And there's a few things associated with implants that are less common and actually very rare, but we frequently talk about and you should discuss with your reconstructive surgeon, which are anaplastic large cell lymphoma and breast implant illness, which are related to safety, related to some types of implants, which are not always used in all practices. Dr. Berger alluded to sensation preservation. So this is frequently done when we can preserve the nipple and the areola, which is done in some patients. Again, the tumor has to be far away enough from the nipple areola so that we can keep it. And then the breast already has a nice shape to it so that we can preserve the nipple areola. So when that's done, we can preserve sensation in two ways. One of them by connecting a nerve that comes off the shelf that has been processed, or we can take a nerve from the side of the breast that's not involved in the cancer and transfer it over to try to bring back sensation. Now, the sensation is not like normal sensation. It's not erogenous sensation, but we think with some studies that we can bring back sensation better than not having this done at all. The other type of breast reconstruction is called autologous tissue reconstruction. Can you guys still hear me? Okay, great. Sorry, I think you lost the signal. And that means using your own tissue. So that can come from different areas. So it can come from the abdomen, the belly, that's called the deep flap. It can come from the thighs, that is called the tug flap or the pap flap. It can come from the buttocks, the I gap or the S gap, or it can come from the back. So that's using the patient's own tissues to create a breast mound. It avoids all the complications related to implants, and it's a pretty nice donor site. So let's talk about the options. The most common one is called the DEEP flap. That stands for deep inferior epigastric perforator flap. That just means the vessels that we actually use. So this is a cross section of the belly where we have skin and fat and the muscle. There's little vessels that are less than 1 millimeter in size that really penetrate through that muscle and give blood supply to the skin and the fat. So we get a CT scan of the belly first, and during the surgery, we find those little vessels. We follow them all the way down to the groin where they come from, where they become slightly larger, so about 2 to 3 millimeters. We disconnect them from that area, and we reconnect them in vessels underneath a small piece of rib. This is called microsurgery. We use loupes and a microscope to do this, and it can be a long procedure. You end up with a scar from hip to hip and a scar around the belly button, like a tummy tuck. Half of the belly is used for one side, half is used for the other side, and we create a breast out of it. We can also bring in a little nerve to try to bring back sensation and try to, to create the sensation similar to what I talked about earlier. I'm sorry, I have a little child in the background. And we also have, however, it's again, not like normal sensation, but we do know that with time, even without using a nerve graft, we can bring back the nerves actually grow from the side of the body to try to bring back sensation into the flap. One side takes about 6 hours, two sides takes about 10 hours. Patients have to be admitted for about 2 to 3 days. The first 24 hours are the most important because we watch to make sure that everything is working okay. The advantages are that most of the reconstruction is done at the time of surgery. We're using your own tissues. It's lifelong. It's the best substitute for a natural looking breast. The benefits is a tummy tuck. However, it's a longer procedure. It's a longer recovery time. It's a separate donor site. It may require revision surgeries. There's a possibility of it not working, which doesn't happen very often. We can only use the belly once, and there's obviously more scars because we're operating in another area. Other areas that we can take it from is the buttocks, the thighs as well. Now let's talk about using implants with your own tissue. So that is a procedure where we can take, in cases, for example, of radiation, where we can take skin and fat and sometimes the muscle and swing it over to the breast along with a tissue expander or an implant to recreate a breast. Now, I also want to talk about what we call aesthetic flat closure. So plastic surgeon can be involved in after mastectomies in patients who do not want reconstruction, but do not want redundant skin in that area. So we can do different techniques to try to make sure that we have scars that look aesthetic and to make sure that there are no irregularities in the chest. Now, the advantages of implant and autologous-based reconstruction, which I mentioned earlier, is that it can be used in patients who had radiation, in patients who are too thin or have had a tummy tuck. The disadvantages is the disadvantages of an implant or using tissue from other part of the body. If we have to remove the nipple areola, then we can reconstruct the nipple areola. And that's usually done by either bunching up some tissue, kind of like origami, to make a nipple or an elevation out of it. And other techniques that we use are tattooing. One of our APRNs will do that, and we have, they're involved in clinical and operative care for breast cancer patients. They're certified in tattoo art. Dr. Berger alluded to a technique that we use for prevention. So one technique is called immediate lymphatic reconstruction. Most importantly, to prevent lymphedema, it's the way that we actually remove the lymph nodes by making sure that we try to preserve the lymphatic vessels at the same time. But if all of the lymph nodes are removed and have to be removed, then what we can do is we can try to find those little lymph nodes again by using a microscope. Those are very, very small in size. They're less than 1 millimeter in size. And we find a vein of equal size and we reroute them. We perform a bypass. The suture that we use to bring those together is actually finer than a hair. So you can imagine that that's very small. And our goal is to hopefully prevent lymphedema. This adds about an hour to an hour and a half to the case, and we think by looking at studies that it has the ability to reduce the chances of lymphedema by about 50%. It doesn't necessarily mean that absolutely you would not have lymphedema, but it definitely is worth trying. Thank you very much for listening, and I welcome any questions that may come at the end of this talk.
Thank you very much, Dr. Haykal. And we'll move on to Dr. Mariya Rozenblit. Dr. Rozenblit is an assistant professor of medicine in the Division of Medical Oncology, and she'll be talking with us this evening about updates in systemic therapy. Welcome, Dr. Rozenblit.
Thank you so much. Okay, so I'm going to be talking about systemic therapy for breast cancer. And as we've heard so far, really the treatment of breast cancer is a multidisciplinary approach. And this involves the breast surgeon, the radiation oncologist, and the medical oncologist. And each part of the team has a slightly different goal. So the goal of the breast surgeon is to remove the known cancer, to obtain negative margins, as we heard about, to evaluate the lymph nodes, and to remove involved lymph nodes. The radiation oncologist then tries to mop up any microscopic disease in the breast and the regional lymph nodes. And this is usually done after surgery, so after a lumpectomy. And sometimes in special circumstances, it might be recommended after a mastectomy. And the goal of that treatment is to reduce local recurrence, so the risk of the breast cancer coming back in the same breast. As the medical oncologist, my goal is to really mop up any microscopic disease that might be anywhere else in the body. And my goal is to decrease the risk of what we call distant recurrence. So the risk that this cancer might come back in other parts of the body. And we call that the risk of developing metastatic recurrence. Okay, so how do we decide what kind of medical treatment to offer? And this is a really complex decision that we put a lot of thought into. And we heard a little bit from Dr. Berger about stage. So we think about what size is the tumor, how many lymph nodes are involved, are we worried about any distant metastatic sites? And then we think about the patient in front of us. What is their age? What are their other medical problems? What is their life expectancy? What are their values? And then we also think about additional characteristics. So just as Dr. Berger mentioned, it's not just about tumor size and lymph nodes, it's also about the molecular makeup of that tumor. So we know that whether it's a hormone positive or HER2 positive or triple negative breast cancer, the type of breast cancer has a very different prognosis. We also think about grade, meaning how aggressive does this cancer look under the microscope? And we sometimes do special types of gene expression testing to try to help us figure out what is the risk of this cancer coming back. So in terms of the timing of the therapy, we think about it in two large buckets, meaning adjuvant or neoadjuvant approach. When we talk about an adjuvant approach, that's when we have a discussion with the surgeon and we come up with a plan that we recommend surgery first. After surgery, we think about whether the person would benefit from the addition of chemotherapy. If they have a HER2 positive breast cancer, whether they need HER2 targeted therapy, and then if radiation is needed, and then if it's a hormone positive breast cancer, we would add on something called endocrine therapy at the end. Sometimes we prefer a neoadjuvant approach, and this is often when chemotherapy is recommended before surgery, and this is often done in larger tumors where there might be a lot of lymph nodes that we're hoping to shrink before surgery, or if it's a more aggressive cancer like a triple negative breast cancer or HER2 positive breast cancer. And sometimes we recommend systemic treatment first because how the tumor responds to the treatment can actually be very important information for us as medical oncologists. And when the patient gets to surgery, we are looking for something called a complete pathologic response. So if we did systemic therapy first and the whole tumor was killed off by the therapy and it looks just like scar tissue under the microscope, prognostically, that's very important and predicts a very low risk of recurrence. The radiation question is up to the radiation oncologist and really depends on what type of surgery was recommended. And then once again, if it's hormone positive, we would add on endocrine therapy at the end. So this is an example of an Oncotype. This is a test that we commonly send for hormone-positive breast cancers. And what this does is it takes a small piece of tissue from the original breast tumor and sends it off to a special lab to look at a certain number of genes in the tumor itself that help to predict how aggressive that cancer is and what is the risk of the cancer coming back. And so what the report gives you is a number. And in general, anything above 25 suggests that there's a benefit to chemotherapy. And it also gives you this number called distant recurrence risk at 9 years. And so what that number tells you is over the next 9 years, what is the risk of this cancer coming back in other parts of the body? So coming back as a metastatic breast cancer. And if you take endocrine therapy, it gives you the risk with the endocrine therapy. In general, we know that endocrine therapy reduces risk by about 50%. So if you don't take endocrine therapy, you can double that number. And then it also gives you the number for absolute chemotherapy benefit. And so often if it's a high oncotype, that absolute benefit is usually greater than 15%, and that's when we'll be recommending chemotherapy. Here at Yale, we have developed several different pathways to help standardize the decision for when to send Oncotype. And so wherever you go as a patient across the Yale network, the different physicians will be following the same algorithm. And this can be really helpful because for some tumors that are very small, that have very low risk features, we often don't even have to send an Oncotype. And then for some tumors that are very large and are very high risk, and we know that that person needs chemotherapy, we often don't have to send Oncotype either. And then sometimes there are these gray areas, and that's when these pathways can be really helpful. And if you're a physician and you're on the call and you're looking for some guidance for when to send an Oncotype, you can click the Pathways tab in Epic. And so this has been developed for both premenopausal and postmenopausal women with hormone-positive breast cancer. And then in the adjuvant setting, where somebody has already completed surgery, chemotherapy if they needed it, and radiation, we also think about ways that we can optimize what we call endocrine therapy. So we want to block estrogen in hormone-positive breast cancer. And in addition to our estrogen blocking pills, we now have something called CDK4/6 inhibitors. And these are pills that actually inhibit the cell cycle. So if there's any microscopic cancer cells left over anywhere, it actually inhibits their growth and helps to kill them off. And we often give these in combination with estrogen blockers. And so this is often saved for patients who have a high risk of recurrence. And so we've developed pathways here at Yale to help with that decision making as well. And oftentimes it depends on the tumor size, so larger tumors, higher oncotypes, more lymph node involvement at the time of diagnosis. The other thing that we often think about as medical oncologists is whether somebody is eligible for clinical trials. And clinical trials are really important because it's a really great way to try to optimize therapy for someone that we're seeing and either get a drug early before it's on the market or hopefully get just a better approach to treatment. So one of the big questions currently in the field is, can we think about ways to de-escalate chemotherapy in young women with hormone-positive breast cancer? And the reason why this comes up is because after doing this for many decades in breast cancer, we're not sure if it's really the chemotherapy drugs themselves that are showing benefit in this patient population, or whether it's the chemotherapy putting these women into early menopause, and whether it's actually the menopausal status that is causing the benefit that we see. So there's currently a clinical trial being run by the NRG called BR009, and this is looking for young women who have oncotype below 25, which we generally think of as low risk, but they may have a positive lymph node, and randomizing them to chemotherapy, which is the standard of care, versus not doing chemotherapy, but really optimizing their estrogen blocking and putting them into early menopause. And so this is an important trial and something to think about, especially if you are a young woman being diagnosed or you know somebody who's being diagnosed, because we're really starting to think that maybe it's not so much the chemotherapy, but the actual menopause status that may be benefiting these young women. And then we also know that there's probably a subgroup of hormone-positive breast cancers that are really high risk for coming back. And so how can we escalate and optimize treatment for those patients? And so there's a trial being run by SWOG here at Yale called 2206 that is looking at something called MammaPrint, which is very similar to Oncotype, but is a different assay looking at a different set of genes. And for patients who score in that really high risk category called high risk 2 or MP2, they're being randomized to adding immunotherapy to chemotherapy. In general, we don't think of hormone positive breast cancer as a cancer that's very responsive to immunotherapy, but we think that there might be a subgroup of these very aggressive, fast growing hormone positive breast cancers that may benefit. And that's what that trial is looking at. We also want to think about how can we tailor chemotherapy for triple negative breast cancer. And so there is a trial also out of SWOG that is looking at patients with early stage triple negative breast cancer and randomizing to standard of care chemotherapy versus standard of care chemotherapy, but without the AC. And the AC drugs, often referred to as the red devil on the internet, are the ones that have the most toxicity in terms of the chemotherapies that we use, and also have a small but significant risk of potentially heart failure in the future. So we would like to avoid them as much as we can. And so we're hopeful that because triple negative tends to be more responsive to immunotherapy, we're hoping that this trial will show that we can avoid anthracyclines or AC in the future. And so the other thing that I think about for hormone-positive breast cancers in particular is how can we tailor our treatments to decrease the risk of late recurrence? So in general, most breast cancers, if they come back, they often come back in the first 5 years, but hormone-positive breast cancers can come back late, so even as far as 10 years out sometimes. And we don't really have a good way to detect them besides continuing to screen with our breast imaging with mammograms and ultrasounds. So this is a trial called KATE that is now open at Yale and will be open across several different sites through the TBCRC. And this is looking at using a novel test called circulating tumor DNA to see whether we can detect cancer coming back at just the microscopic level. And so for patients who are more than 5 years out from diagnosis with hormone-positive breast cancer, who have completed all of their prior treatments, on this trial, they can get the ctDNA test, which is a blood test, every 3 months. And if they end up coming back positive on this test and they don't have cancer yet on their scans, we're going to be treating them with elacestrant, which is a pill. And it's one of these newer estrogen receptor degraders. So not just a blocker, but actually degrading the estrogen receptor. And we're hopeful that by intervening at the microscopic state, we can prevent these cells from growing back into a tumor and growing back into a breast cancer recurrence. So thank you very much. And I hope that if you're a patient or a family member or a treating physician, that you think about clinical trials or at least discuss clinical trials with your oncologist. Thank you.
Thank you very much, Dr. Rozenblit. So we've answered many questions in the chat. This has been a fast and furious overview on updates in early stage breast cancer. We learned surgical therapy from Dr. Berger, options for reconstruction from Dr. Haykal, as well as updates in systemic therapy from Dr. Rozenblit. I think the last thing we'd love to share with our attendees is that we do make decisions as a multidisciplinary cancer team. So patients that come to any site across the Yale Smilow network will meet with a medical oncologist, surgeon, radiation oncologist, and plastic surgeon. And we work as a cohesive, united team in patients' care. I think there's one last question in the chat, Dr. Rozenblit, about a lobular carcinoma with an oncotype of 34 and some concern about how estrogen gene expression being borderline positive and how that information influences your recommendations for systemic therapy.
That's a great question. So Oncotype was really designed to answer the question of, is there benefit to chemotherapy or not? And it really wasn't designed to kind of investigate how hormone positive a breast cancer is. So we still do rely on looking at the tumor under the microscope, and that would be a discussion with your team, including the pathologist, in terms of how much estrogen positivity you're seeing in that case. In general, even for borderline positive cases, it looks like in this case it was 90% is what I'm understanding from the report. We would go ahead and treat that as an estrogen hormone positive breast cancer. There are borderline cases where the estrogen positivity is very low, and that becomes just a very complex discussion with your medical oncologist. And in that case, they might tailor the chemotherapy and offer you a slightly different chemotherapy if it's borderline.
Thank you very much. There's another question about what we recommend for young women who are thinking about future pregnancy and have an estrogen positive tumor. Unfortunately, the positive trial, which was run out of Dana-Farber, but included multiple institutions across the country and the world, did look at young women, they were 42 or younger, who were treated for hormone receptor positive breast cancer and received between 18 and 30 months of anti-estrogen therapy or hormone endocrine therapy to target their breast cancer. They went on to take a break for pregnancy and potential breastfeeding, and their pregnancy success was very good, as well as the risk of a recurrence was similar to the women who did not go ahead with pregnancy. So the data we currently have is showing great promise that it's safe for select women with hormone receptor positive breast cancers to take a break for pregnancy and future breastfeeding. And this is certainly something you should discuss with your oncology team. It's important that you're at a right stage of your cancer treatment and that we can monitor you as well as possible during and after pregnancy. There's another question about a recent article on spike proteins and the aggressive new cancers. Dr. Rozenblit, I defer to you if you're able to answer this question.
I don't see this question about the spike proteins.
It says, any comment on the recent article on spike protein and aggressive new cancers?
I'm not exactly sure what this article is referring to. There is a lot of research out there trying to figure out better ways of predicting aggressiveness and recurrence. So that's probably what that's referring to. It's nothing that has reached, standard of care yet. It hasn't entered mainstream practice. But yeah, I look forward to reading more about it.
Okay. And then there's another question about tracking recurrences and HER2 positive versus hormone receptor positive, HER2 negative cancers. I'll dive in very quickly as a surgeon. I think locally we're examining your skin. We're looking at any changes. There was another comment and question in the chat. There can be ongoing changes in the breast tissue after surgery, reconstruction, and radiation for even a couple years, but most cancer patients should be under surveillance with their oncology team. We decide to survey people for a distant recurrence in the setting of symptoms or abnormal labs. And Dr. Rozenblit's really an expert in ctDNA. So I'll turn that over to her.
Yeah, so the main surveillance mechanism, like we mentioned, is physical exam and then breast imaging. In breast cancer, we have not seen any benefit from PET scans or CAT scans, and so we don't do them because the risk of the radiation from the scans actually outweighs any benefit in terms of finding a recurrence. And we don't have good blood tests either. There are blood tests out there called tumor markers, and we use them for metastatic breast cancer all the time. But for early stage breast cancer, they've been shown to have what's called low sensitivity and low specificity. So they can be negative and there can still be a cancer, and they can be positive and there can be no cancer. So they're not very helpful to us. And that's why we're trying to develop this new blood test called circulating tumor DNA. Right now, we're looking at it just in the research setting because we don't know yet how helpful this test is, and we don't have a treatment option. We need to investigate what treatment we can give if that test is positive. So there are trials going on for that for both hormone positive and HER2 positive and triple negative breast cancer. So if you're really interested, please look out for those trials. They're in very early stages, but we'll probably see more of those clinical trials in the next couple of years.
All right. Well, thank you to my esteemed colleagues for joining us tonight and sharing your knowledge. And thank you to all the attendees for joining us for the Smilow Shares. We encourage you to attend our future sessions in the month of October, which, as many of you know, is Breast Cancer Awareness Month. And please reach out to any member of our program if you or family or friends need to be seen. We wish you all well, and thank you again for joining.